So, as Ben said, my name is Dr. Gil Davison from Belfast, and I'll be talking on acute asthma. And it's within the current theme, obviously, of awaiting the retrieval team. So, this presentation aims then to address just specific concepts of near fatal asthma within the management of being within a DGH rather than an exhaustive sort of overview of everything asthma. So, we'll be focusing on use of IV bronchodilators, the risks prior to and during intubation, exploring some of the human factors, and looking at post-intubation stabilization. So let's consider a case. It's a hypothetical case. It's an 8-year-old boy called John Knox. So you're working in a DGH one evening and you've been asked to review an 8-year-old boy on a paediatric ward. He presented 12 hours ago with a 2-day history of a cough and coryzal symptoms, and then had acute onset of increased work of breathing that morning, despite 2 puffs of salbutamol at home. In ED, he received 3 back-to-back nebs of salbutamol 5 milligrams and epinephrine bromide 250 milligrams, and then he had hourly nebs thereafter. He also had dexamethasone 12 milligrams and magnesium sulfate 40 milligram per kilogram. So he seemed pretty sick, but actually he improved in ED and then was moved to the ward and was just on 2 litres of oxygen to maintain his SATs at 92. He also had a chest X-ray at admission, and it showed perihilar bronchial wall thickening, just some viral changes and some hyperinflation. On the ward, he was relatively stable for a few hours, but then he deteriorated. And in the last 2 hours from now, he deteriorated, and the ward SHO gave him a further 3 back-to-back nebs, a bolus of IV salbutamol, and then started him on IV salbutamol infusion at 1 microgram per kilogram per minute. On assessment now, his saturations are 90% on 100% high flow at 40 litres per minute. His respiratory rate is 44. He's poor air entry bilaterally. He's not able to speak in sentences. He has a high heart rate and a sinus tachycardia, and he's a high blood pressure, and he appears anxious and tired. And his blood gas, pH 7.35. As you can see there, lactate's high at 4.2. His potassium of note is normal. So for this case, just like you to tell me then what your management would be, looking at the options here. So do you increase the IV salbutamol rate to 2 micrograms per kilogram per minute? Do you repeat the chest X-ray? Do you give magnesium sulfate nebulizer? Do you give IV hydrocortisone? Do you call the PICU team and prepare for intubation? Or the other option there, do you get some physio suctioning and DNAs? So just a variation of responses there, but IV hydrocortisone seems to be a top one. Increasing the salbutamol rate sort of comes thereafter. Giving mag sulf, repeating a chest X-ray. I don't think many have chosen the physio. So let's go through them. So intravenous salbutamol. So yes, salbutamol is one of the mainstays of treatment, bronchodilator. The standard pediatric dose is 1 to 2 micrograms per kilogram per minute. Now this is fine if the patient is 10 or 20 kilogram size. But remember that the maximum dose, which you cannot exceed, is 20 micrograms per minute. So that means if you have a 20 kilogram child and you're starting them on 1 microgram per kilogram per minute, then actually they'll already be at the maximum. So any child who's heavier than 20 kilograms, you'll risk giving them salbutamol toxicity if you don't know the maximum adult dose. So this child had significant salbutamol toxicity with hypervigilance, anxiety, tachycardia, and lactic acidosis. And the lactic acidosis was driving the tachypnea. And this was caused by, the bolus of salbutamol and the infusion at the increased rate and co-administration of nebulizers. And this lactic acidosis with tachypnea can actually resemble worsening asthma. IV treatment then should be reduced to 20 micrograms per kilogram per minute, and the neb stopped, and you need to monitor the patient for improvement then. So just of note as well, lactic acidosis, sort of driven by beta 2 agonists, can be distinguished from acidosis driven by tissue hypoxia by calculating a lactate pyruvate ratio. Now, I've never done this myself in practice, but just reading on it. In severe asthma, lactic acidosis is driven by hypoxia, hypotension, and liver hypoperfusion and overproduction by respiratory muscles. Whereas in salbutamol toxicity, the beta 2 agonist leads to increased intracellular cyclic AMP, glycolysis, lipolysis, fatty acid production, and then this diverts the metabolism of pyruvate from the Krebs cycle towards lactate. So in this patient, we could hypothetically expect the type B, where you have a increased ratio greater than 25. So one of the options was a chest x-ray. So a chest x-ray is definitely worth doing on any presentation of a child in respiratory distress, near fatal asthma, initially sort of to check for any underlying cause, a mediastinal mass, lung collapse, consolidation, and what their expansion is. As well, in this patient, because he had improved and then deteriorated, you might want to look for a pneumothorax. So this child didn't have a pneumothorax, but here's what you need to be looking for. Also, we had on the options magnesium sulfate. There's no evidence for magnesium sulfate. There is weak evidence, and it is in the APLS algorithm, but it's only for within the first hour. So for this patient, it wouldn't help. IV hydrocortisone, well, the child's already received a good dose of steroids, but considering that they've deteriorated, it would be worth giving them a dose of IV hydrocortisone, and then they'll likely go on to 6 hourly IV hydrocortisone of 4 milligram per kilogram subsequently, but it probably won't change sort of the patient's outcome immediately. For physio DNAs, suctioning, a bit of suctioning might be fine, but you won't be doing anything extensive because the patient will not manage. So you might want to call PICU just at these early stages, and maybe just to set up, but maybe expecting the patient to improve after you've reduced the salbutamol. PICU would probably rather be called earlier rather than later to be aware of the patient and to maybe guide management thus far. So this patient, so if we're imagining that he's sort of deteriorated further then after you've reduced the salbutamol, then you'd be thinking about intubation. I know we had chatted about this earlier, and Shilpa was querying in regards to intubation. Maybe the patient is too sick to be moved or too sick to intubate. Well, there isn't a magical number or a sort of definitive indication, but certainly the decision to intubate is a clinical one based on hypoxia, based on impending respiratory failure, and based on dropping GCS. So ongoing deterioration at this stage for John Knox would mean you'd be strongly thinking about intubation, and the deterioration is likely not due to bronchospasm at this stage, but due to mucus plugging and alveolar hyperinflation and increased dead space with ventilation perfusion sort of mismatch. And then the need for positive pressure ventilation is more acute. But intubation won't cure the patient. It'll just mean that the disease process is on the end of a tube. So for a sick asthmatic, if John needed intubated after deterioration, then you would be probably wanting to use a 5.5 millimeter microcuffed tube, cuffed so that you can reduce air leak. You probably want to use ketamine, 1 to 2 milligram per kilogram, and ketamine has a good bronchodilator effect. And you'll be using rocuronium, 1 milligram per kilogram, plus or minus fentanyl, and doing a bit of slow bagging. Now, today we've talked about how teams work together, and we've talked about sort of human factors. And I'm coming from the perspective of working in the Paediatric Emergency Department. So thinking about that, then I've created a video, and on the next slide, I will show a video of a paediatric and anaesthetic team setting up for intubation. And I've simulated this to happen in possibly a district general theatre for our patient, John Knox. So for this video, I've one video and then a subsequent video. You can assume that all of the staff know each other's names, specialties, and grades, and you can assume that there's ongoing cardiac monitoring. And you can assume that John had subsequently deteriorated after reducing the dose of IV salbutamol, which meant there was a more acute need for intubation. So while watching the video, if you're able to type some comments into some note function on your device, and then you can paste these in to the Slido when the Slido appears in the next slide. But if you have the comments ready, that would be convenient. Hi guys, so I've just been on with PICU and the retrieval team, and so a few of you have just joined, so I'll just recap. As I said, this is John Knox. He's an 8-year-old boy. He was admitted this morning, came in through ED, had back-to-back meds and Magsoft for acute exacerbation of asthma, and seemed to get better but then deteriorated. Was started on IV salbutamol, 30 micrograms per minute. We have since reduced that to 20 micrograms per minute, but as you see, he's not great. He's deteriorated. His OBS aren't great. His respiratory rate is 44. His saturations are 90 there, and that was with the high flow on at 100%. He's poor entry bilaterally. His heart rate's 145. Blood pressure's up 134 over 72. Pulmonary flow's okay, but he's anxious and he's quite tired. So the advice from PICU is that if we feel he needs intubated, then to go ahead, and they will be here in due course. So considering his assessment, I think it's appropriate to move to intubation. What does the team feel?
Yes.
Sammy, your anaesthetic reg.
Yeah.
Are you happy to do the intubation?
Happy enough to crack on.
Okay. And you phoned your consultant?
They're on their way in, but it won't be here on time.
Okay. And do they feel it's okay for you to proceed?
Yes, I've done this before, many times.
Okay. And you've managed children's airways before?
Yeah.
Okay. And what's your intubation plan?
We've got a 5.5 tube, I believe, and we've got some PET and rock 1 per kilogram per up, and I think we should be ready.
Yeah, I think so. Yeah, we're ready.
Okay, so you're ready, great.
Yeah.
And then Amy, you're on breathing, or sorry, you're on circulation, Amy. We'll go to Mohammed, you're on breathing. Mohammed, do you want to listen to the test then afterwards? Dami, is that okay for Mohammed to listen and confirm? And do you want Mohammed to check the sats?
Yes, if you can give it this bit of saturation, I'm sure it's okay.
And do you want to be alerted when the sats are low?
That'll be very helpful.
Less than 80 or?
Less than 80 would be good, yes. We've got all that stuff ready, I believe, to change around.
Grand. And then Amy, you're in circulation. I think it would be worth if you do the drugs, administer the drugs. You've checked the dosages there with Dami, have you?
Yep.
And if you're able to give the 10 ml per kilo bolus
Grant, I do that now?
after, well, if you give the bolus after the drugs,
Grant, yeah, sure, I do that.
okay, just to keep that blood pressure up. And then if you just keep a finger on the pulse then during the intubation and after the drugs.
Ready, yeah. Is that the right size of weight? Probably is that, you know what, it's fine, let's just have that one.
So is everyone ready?
Yeah.
Okay.
Happy for me to go ahead and give
Yes.
Go ahead.
it?
Okay, so that's the end of the video. So as I said, it's just a simulated sort of setting up for intubation, and the question is, what are the risks of intubation and how did the team prepare and mitigate for these? Now, if there's any other comments you want to put in, feel free to do so. Constructive criticism is appreciated. So some of the comments: clear handover, S-bar, current situation explained, query about the cardiac arrest prep, hypotension, fluid bolus given, cardiac arrest prep, no clear plan, which is correct. Anesthetic reg would not do this before consultant arrived, probably right. Risk of arrest, close monitoring, yeah. did not prepare for difficult airway yet. There was no further plan. So yeah, all great points. So we'll move on. We'll have a second video.
Hello, I'm Amy, the Paediatric. I've just spoken to ICU and the trauma retrieval team. They have advised us to intubate if we feel like it's clinically indicated.
Okay. And are they on their way
They're on that, yeah.
to give us a ETA?
Oh, sorry, I didn't get an ETA now.
Okay. No, that's grand. Thank you, Amy. So Amy, Mohammed, you've just arrived. So we'll just recap. So this is an 8-year-old boy, John Knox, who was admitted this morning through ED. And went on to the ward, had back-to-back nebs and IV magnesium sulfate, but deteriorated. Was then put on salbutamol, has some salbutamol toxicity, so we've reduced the rate from 35 micrograms per minute down to 20 micrograms per minute. Our clinical assessment at the minute is that he's sort of an extremis. So his respiratory rate is 44, quite high. His saturations are 90%, and that was on the high flow that's since removed. He's poor air entry either side. He's heart rate of 145, his blood pressure's up, he's anxious, he's pale, clammy, and he's tired. So I think based on that clinical assessment that it would be appropriate to intubate at this stage rather than waiting any longer. I don't think we have sort of any time to wait because he could deteriorate further and go into cardiac arrest. And we know that PICU are aware that he's here and the retrieval team are on their way. Sammy, what do you feel about that?
Yeah, I think I'm quite worried about him really. I've had a chat with my consultant there and we're waiting because I'm really worried about what you said he might arrest. But I do agree that yes, we do have to plan to intubate because we do not have time to spare.
And as your consultant, and are you happy for you to intubate at present?
My consultant is on their way, but I think in the room I'm the most experienced to intubate this child, but my consultant is going to call me straight away because I'm quite worried about them.
And you've managed children's airways in the past, or you came from adults?
I have.
Yeah, okay, for your experience, that's great. So are you ready in terms of your intubation equipment?
We've got an ET tube ready at 5.5 for our first plan, and another attempt size down if we have challenges with the first one, and our plan C will be LMA until my consultant gets here before we have further attempt. And we have our drugs ready, I believe, 1 milligram per kilogram of ketamine and 1 milligram per kilogram of lopinonium with flushes.
Okay, that's great. So you have a plan ABC. And did you see our checklist there? Have you
Yes,
been
the
done?
checklist has been confirmed for the pre-intubation. So we're happy enough, ready to go now.
Okay, great. And then we'll come to breathing. So Mohammed, will you be happy, Danny, for Mohammed to keep an eye on your saturations?
If you're happy, yes.
Yeah.
And my chest and entries as well.
And do you want an alert?
Yes, when it starts on video 18.
Okay.
Thank you.
Okay. And then after the intubation, then Mohammed, if you have a listen, and there might be a chance this child could then progress to tension pneumothorax. So would you be happy to assess for that and to treat for that?
Yes, definitely, I would be.
You're happy with that? That's great. And then Amy, you're on circulation, so you want Amy to give your drugs?
Yes, if you're happy.
Yep, sure, I'm happy. Yeah.
And you've checked them with Danny, have you?
Yeah, sure, Danny. Just double check the doses for me again.
Ketamine 1 milligram per kilogram.
And he is good at his.
So fine.
Yeah. Grand and rockronium.
1 milligram per kilograms as well.
Grand, great. Okay. Yep. Okay, yep. Got those.
Great, and you have 2 cannula in anyway, so you have 2 access. Now, circulation might be an issue, and it was great that we were able to get that arc line in, so we can keep an eye on it. But give the first fluid bolus anyway. If the map then drops, based on the arc line measurement, if it drops below 70, then give the first dose adrenaline.
Okay.
So the first dose adrenaline is the 1 in 100,000. And you've double checked that with the nursing staff, haven't you?
Yeah.
Great, that's great. And you've sort of drawn it up there, and there's a 3.5 mils of 1 in 100,000. Okay, that's great. And then you have the rest dose adrenaline as well.
Yeah.
Okay, because there is a chance that this child can go into cardiac arrest. So if a cardiac arrest was to occur, then if you're able to stay on the drugs, and then if that was to happen, Mohammed, if you could get the defib and the ultrasound machine to check for a tension pneumothorax, and the defib obviously to check the rhythm and deliver shocks. And we'll have our wet flag done so we're aware of the dunes that we need. Okay, so I've given you a few extra things to get there. Do you want to go and get them and get back to me when you're ready? Okay, hopefully it'll just be a few minutes.
Want me to go ahead and get the drugs to everybody's ready?
Okay, so I'm handing over team leadership to you, Dami. But me and Amy will focus on the circulation if you stay with the airway.
Okay, so that's ketamine going in.
Okay, so that's the second video and the second sort of team scenario. So if you could enter a few comments in. So we appreciate the comments before were that the first team didn't appreciate or didn't set up for cardiac arrest. There was a few sort of failures there. So if you want to sort of even compare, thinking about human factors as well. And I appreciate that in many specialist centres such as PICU, you've got maybe a team where the team will come together quite frequently and everyone knows each other. Whereas in a DGH, you're going to have teams that don't know each other and don't have possibly a shared mental model until they come together. So we're hearing that it was structured, valid concerns from the reg, intubation checklist used, odd to do it in a mannequin. We don't have anything else. Didn't focus on air trapping. So yeah. Was the first dose adrenaline too high? Well, it's 0.1 mil per kilogram and the child was 35 kilograms. So that's why it was 3.5. Step-by-step approach, structured approach. Took time to go away and get more equipment. So yes, so I suppose the aspects of that. The bibs are quite good, although we don't use them all the time. But they were created for trauma scenarios. But we actually find that even in simulations and resusces, that the team, by wearing the bibs, go into the roles themselves. As well, I suppose, with getting them to go away and get the equipment and come back, then you've got that closed loop communication, which works very well. And as we know, with the technical side of what needs done for the patient and then the non-technical side. So just move on to some sedation and ventilation. So naturally, after you've intubated the patient, then you'll be confirming the ET tube position with auscultation, chest X-ray, and expiratory CO2. The sedation for a sick asthmatic then probably want to avoid morphine. So you might want to use fentanyl with midazolam. As you know, morphine gives a histamine release. And then you really want to muscle relax the patient, either by giving boluses of muscle relaxant and then moving on to infusion. Ketamine might be worth adding as well because ketamine has bronchodilator properties also as a ketamine infusion. So in terms of ventilation, yes, I never covered this within the simulation, but slow bagging initially, and then you can manually decompress the chest if you feel that there's stacked breaths, and using the dope mnemonic with dopes with the S on the end. So what I mean by that is, yes, with a sick asthmatic, there'll be issues with expiration. And sometimes when you're bagging, you bag too quick. So you need to slow down the bagging in order for the air to be released in expiration. But if air has accumulated in the chest without adequate expiration, then you'd need to disconnect the child from the ventilator or from the bagging circuit, and manually press on the chest, and you'll hear a hiss. So you're going to put the child on PRVC ventilation is the standard, And the respiratory rate, you really want it low. So you're probably going to start with the normal respiratory rate and lower that subsequently. The tidal volume, you want between 4 and 8. And then the expiratory time, you want good expiration. So you maybe start with 1 to 2, and then move that on to 1 to 3 or 1 to 5. As you can see from these sort of ventilator flow curves, you can see the first one there, A, is normal. So you have inspiration and then a full expiration where the line is going up, going back up here. So there's been full expiration. Whereas in B here, you've had inspiration and then expiration has been insufficient and it hasn't reached the line here. So there isn't adequate expiration. In this circumstance, sort of where you're seeing this, then you really want to reduce the respiratory rate and increase the expiratory time to optimize ventilation. Other therapies, or just the PEEP as well, you probably want an adequate PEEP in order to keep those alveoli opened that you've recruited. So a PEEP of at least 5. In terms of pressures, so for a sick asthmatic, you'll really be using quite high pressures that could go up to 40. The peak pressure isn't as important as the plateau pressure. So the plateau pressure, you'd want that to be less than 35. And here you can see, you've your peak inspiratory pressure, but you've actually got your plateau pressure here. And if you do an inspiratory hold, you'll be able to find out the plateau pressure. And the plateau pressure is what is the pressure being delivered to the alveoli. So that's why it's more important to identify the plateau pressure. The peak pressure will give you the pressure in the airways, but by doing the inspiratory hold, you're allowing the gas flow to settle, and then identifying the plateau pressure. So you'll be wanting to obtain permissive hypercapnia. You won't be wanting a normal CO2. And in the expiratory CO2, you'll be wanting to aim for less than 10. If you were to try and gain a normal CO2, then you would likely cause barotrauma, which wouldn't be good for the patient. And you'd want to aim for a pH of greater than 7.2 and SATs of over 92. So additional therapies, which we won't be covering in this talk, would be ECMO, DNAs via bronchoscopy, physio and SIVO. But as this talk is about the retrieval team coming out, then that would be further therapies that are beyond the scope of this talk. But that's me. Thank you very much for listening. And there's the feedback code.